rapid fire presentation, and first up is Ian Griffiths.
Morning all. How are we all feeling? Yeah, same. Okay, let's go. We've all got something that can walk into our clinic and have the ability to make our heart sink, I think. And for me, historically, it's always been a runner with medial tibial stress syndrome. Now, the reason for this is that it's a load-based problem, and therefore, to get a successful outcome, you're going to have to manage load successfully. And this is going to involve getting the runner on board with that. They're going to have to dial back their running, or sometimes even stop running for a period of time. And I find this a challenge sometimes. I don't know whether it's where I work or the demographic I see, or maybe it's me, but sometimes they're reticent to do that. And they quote a charity race, a charity place they have in a race, and they don't want to let someone down, or sometimes they're just runners, they're just stubborn. So the way I've always sort of thought to attack this is to educate them to within an inch of their life, to essentially have them understand as best possible what we think causes this problem and how what we're asking them to do is going to positively feed into that. There's also a nice option of having a backup, and the backup here is, what if they really won't or can't stop running? Is there anything we can do to modify their pain whilst they continue to run? And that's what I want to come on to talk about, which is a changing of a particular facet of running technique that we can modify. But we'll do some of the revision stuff first. So when I was at university, the prevailing theory at the time was that the primary cause of MTSS were the tensile forces, this sort of tractional tugging or pulling on the posterior medial border of the tibia from tissues such as tib post, FHL, and soleus, usually thought to be secondary to some sort of mechanical behaviour of the foot more distally. And if we look at the anatomical studies, the cadaveric studies, the three big ones are all in agreement with this. The most commonly reported location of symptoms in MTSS and the attachments of the aforementioned tissues correlate very poorly. And there's been a very reasonable question raised, which is, can we still blame these tensile forces for being the primary cause of the problem? Some authors have suggested it's far more the tibial bending moments that we need to consider. And this is a fancy way of saying the forces that are trying to bend the tibia. The tibia is a curved structure, and we load it from above and below when we run. And when you load any curved structure from both ends, those forces will try and bend it. And ultimately, the bending forces in any structure will probably be at their greatest where the structure is at its lowest cross-sectional area, which for the tibia, would you believe, is pretty much exactly in the middle of that zone where people report their pain. Now, what we need to acknowledge is that not everyone who runs develops medial tibial stress syndrome. So we have to ask the question, why do some people, or why do some tibias have the ability to cope with these forces, and why do some tibias have the lack of ability, or the lack of capacity to cope? Now, this is a bit of a mechanically biased talk, but we have to consider that there's, and it was mentioned yesterday about how important the history is, there are things we can tease out in the history that will give us clues about reduced tissue capacity. So, as an example, if a 55-year-old lady comes in who is a vegetarian and she's 45 kilograms in weight, she reports that she is going through the menopause, she has a family history of osteoporosis, I'd like to think we wouldn't be thinking about retraining her running, or even foot orthoses. We should probably be thinking more along the lines of referring on for sort of bone profiling to see about her tissue capacity. That said, the majority of our cases, mine at least, are going to be fairly classic mechanical overload type of scenarios. And this is how I get the patients on board with this analogy. This is how I personally try and educate them. I use the analogy of water and a bucket, where water is the load and the bucket is the capacity of the tissue. In this case, the tibia, but this pretty much works for any tissue. And it's pretty much as simple as this. If you don't want to get injured, don't overfill your bucket. It's ultimately that simple. Now, obviously, we have to extrapolate this analogy slightly and remind our patients that their buckets, their tissues, are human. They will adapt to external loads. So, if we drip feed some water into a bucket in a slow and steady and progressive fashion, that bucket will grow in size. So at some point in the future, we can put more water in it without overloading it. They have a better capacity for load or water. The converse is depressingly true as well, in that if you don't put enough water in your bucket, it will begin to shrink. So that at some point in the future, it's far, far easier to overload it when you put some water in it, or when you apply loads to the situation. Excuse me. So we've all heard these stories in clinic. The fairly classic one, someone who's been sedentary for a couple of years, they've had a good Christmas, they're feeling a bit guilty about their indulgences, they put on some timber, they run 10k on January the 5th. And they come into clinic because they've developed shin pain. And you essentially come around to saying to them, you've dumped a litre's worth of water in a bucket the size of a coffee cup. And deep down, they know they were foolish. They aren't the ones I find that are difficult to get on board. The ones I find are the runners that have run for a long time and never been injured before. They've run 10k every Sunday for as long as they can remember, and they've never, ever had any problems. And then life gets in the way, as it does for all of us at some point. So one of their children gets sick. They have a crazy few weeks at work. They get sick. And before they know it, they've not run for 5 weeks. And they suddenly think, I need to get back on this. So they put on the same pair of shoes, same pair of orthoses, they run at the same speed, the same distance. They essentially, in their mind, do an identical run to they've always done, and they develop shin pain. And they sit in our clinics utterly bamboozled as to why this has happened. I don't understand it. Because everything I did was the same. And you need to tell them the water was the same, but the bucket was different. You applied the same load, but a 5-week hiatus from running is absolutely long enough, way longer than long enough, for that bucket to start shrinking. So you used to put a litre's worth of water into a 2-litre bucket, but what you've now done is put a litre's worth of water into a half-litre bucket. And again, coming back to the history, because we know it's king, there's going to be psychosocial things that feed into this as well. So that 5-week break, it's not just the break from running. Sleep deprivation, stress, anxiety, illness will all influence tissue capacity as well. Once they know this, once they're on board with this, then when we talk treatment, they should be engaged. And whether we're talking about proximal rehabilitation, we're talking about rest from running, footwear, foot orthoses, running retraining, ultimately we can frame it that we're trying to get this load capacity balance back. And there's no denying the most successful outcomes are going to involve a reduction in load initially, an increase in capacity for load, and then a slow gradual reintroduction of load, and education to stop this happening again. Enter, possibly, running retraining. Now I want to say from the outset, we do not use this indiscriminately. It is not appropriate for our osteoporotic vegetarian. But it's a good arrow to have in the quiver. It's a good option to have. This was a classic example, and we've all had this story as well, I'm sure, of a runner who could not get past 6k without her shin pain sort of debilitating her to the point where she had to stop. And she was running a 10k race in 3 weeks. And that was her statement to me. I am running a 10k in 3 weeks. She was running in the memory of a loved one who'd passed away. Now, I'm not going to argue with that. So she'd done everything that was asked of her to that point. She'd done her proximal re-education. She was wearing good footwear. She was wearing foot orthoses. She presented to me 3 weeks out and we sort of said, is there anything else we can do? So we had a chat, we talked through it, and we talked about changing the way she was running to see if that would help. What we do, we get on the running track in the clinic and we ask her to straddle the lane and without overthinking it, just run, just so we can get a baseline of her step width. And with her, as you can see on the left, every single foot plant pretty much hit the line. She was almost running down a tightrope. That was her sort of default step width. And we asked her to walk back to the start of the track, straddle the lane again, and this time, although it's going to feel weird, we ask her to look down at the line a little bit and to miss it. And not John Wayne miss it. Miss it as marginally as she can. So scrape it left with the left foot and right with the right foot. And what we've effectively done is increased her step width by the width of the line. We've given her one cue to focus on. Hopefully what you can see with the before and after is we've changed the frontal plane alignment of the entire leg. We've reduced the running limb varus, and our thoughts are we've changed the vector of loading through the limb. The goal of this is plain and simple, to reduce the tibial bending moments. Now, it has its limitations, like all interventions. It's not for everyone. It has its pros, its cons. We probably don't have time to go into those now. Happy to host an unconference session with someone if you want to do that, and we'll go through it, or just grab me a coffee break. But ultimately, it's a nice option to be aware of. It won't be new to some people. I know there's faces in here I know this already, but it's nice to put it on everyone's radar, I think. The good news about this, we want to be evidence informed, and the good news is there's not lots of evidence. I say that's good, it sounds bad, but what it means is you don't have to read loads to get up to speed. And this is the key paper. If you put Stacey Mearden's name into Google Scholar, Stacey Mearden, tibial stress should be enough. It's full text PDF on Google Scholar of this paper, and her and Timothy Derrick showed that sort of consistently as people increase their step width, the stress in their tibia decreases. So that's the kind of the evidence base we have at the moment, but it's an emerging field, so it's clear that there's more work to be done. I want to thank you so much for your time, your attention. I want to thank Martin for putting me on at 8:30. on the morning after a night out in Ireland. That's delightful. Appreciate it. Thank you.
Thanks very much, Ian. I knew you could pull it off at 8:30 in the morning, so well done. Okay, next up, Ruth.